Thanks very much, Ben. Steve, you thought you had the graveyard shift after lunch. I'm standing between people and their coffee. How the bloody hell do I follow that? Brilliant, though. Brilliant. Polypharmacy and the Orange Book. It's going to be fascinating.
Well done, John.
Apparently I'm an expert in prison medicine. An expert is someone who's made every cock-up that it's possible to make, and I've made them all. I've got various disclosures to make because people have paid me to say things. My favourite is the bottom. Pfizer wanted to have a meeting with me over me rubbishing pre-gabs, but I said no. I think they might have a contract out on me, but I'm not quite sure. I did once go to do an after-dinner speech for the Transpennine Pain Group, talking about neuropathic pain management and drug addiction. And I completely rubbished pregabalin before realising that they had funded the meal. So that went well. So, turning to the Orange Book, as we must. It's a fantastic resource, actually. I read it specially to do this talk. But I also used PDF search and used the search term polypharmacy and went through, and that's how I identified the paragraphs that I'm going to refer to. But interestingly, they concur very significantly with everything we've heard throughout today. So I think that the ambition for a consensus statement coming out of this meeting is perfectly achievable and maybe more robust than we had originally thought. So, polypharmacy, we know it's a big problem. Thank you for pointing out that there's no RCT on 4 psychotropic drugs. Once you're on more than 2, we don't even know what the interactions are between them. So polypharmacy is generally a pretty bad idea, and it's always been said that the best prescribers prescribe the fewest drugs. So our particular patient group love their polypharmacy. It's what they do in the community, it's how they use drugs, and it's how we get grafted.
I'm just very good.
Well, I'm from Birkenhead, so
yeah.
So yeah, benzos, antihistamines we've heard about. Mirtazapine is an antihistamine-mediated sedation as part of its antidepressant activity. We've heard about the anticholinergics. I think we've got the same list of drugs that we've seen several times there. QT prolongation. Yes, it's a significant problem. I'm not sure that I've tripped over hordes of corpses due to QT prolongation in my career, but nevertheless, we know it's a risk, and we know we have to be a bit cautious. And we're certainly doing ECGs on people who've got high-dose methadone to check on their QTc. Polypharmacy, whether it's a causative relationship or whether it's a result of other frailty, we know that polypharmacy is closely correlated with premature death. And you've got to be particularly careful. Respiratory, liver, we've heard about the number of our patients who have these problems, but also head injury. And we know that head injury is a significant problem from people who've got beaten up for various reasons. So where does polypharmacy start in the secure and detained setting? Well, police custody for sure, but let's focus a bit more on where we can continue and look at prescriptions. So it's reception. Polypharmacy, 2 or more sedating drugs. You've got to be really careful. This is Orange Book guidance, but it also arises from Coroner's Rule 43 recommendations. These are the old style prevention of future deaths before Regulation 28. And the coroners have said, be very, very careful if you're going to prescribe more than 2 drugs. And it's a great get out. I use it in reception all the time. I'm not allowed to give you more than 2 or 3 sedating drugs at the very most. So there's your methadone, there's the mirtazapine that you say that your GP shows that you're on. Afraid I can't give you anything else. Or there's your detox if you need it, but so few people do that that's another thing. I never prescribe any drugs with any abuse potential without confirmation. Now, if I'm starting a methadone detox or a reception methadone regime, the confirmation comes from the urine drug screen. But even that's prone to abuse, isn't it? As we've heard before, if the FME gives some chlordiazepoxide, then the patient can say he's a regular benzo user. We've got to be dead careful. And I only prescribe benzo detoxes to patients who are showing objective signs of withdrawal, in particular tachycardia. So always with confirmation. The vast majority of polypharmacy is unnecessary. It's unsupervised outside. Lots of comorbidity going on. The risks that arise are particularly from intoxication, to some extent from withdrawal. If we have got a patient who's on our favourite clonazepam, incidentally, I've spoken to lots of neurologists over the years and never found anyone who's admitted to endorsing or starting it for epilepsy. So you have all of those risks going on. Diversion and abuse we're absolutely clear on. And the novel psychoactive substances, they used to call it spice, didn't they? It was all synthetic cannabinoids, but it's got a bit more than that. And I'm entertained. I'm never going to use Silibang again. But night sedation, generally not. The only time I will use night sedation as a one-off is someone who's quite agitated and they're only going to start on 15 mils of methadone. I won't use it apart from that. So you get our confirmation, you get the high level of prescribed meds outside. I'm always a bit sceptical until or unless I get GP confirmation. But even once you have got that confirmation, that's not confirmation that the patient was taking the medication. So if you take clonazepam as a very good example, if someone's collecting that from the pharmacy and they're collecting it every 28 days, absolutely religiously, and selling it all, and then we put them on it in the prison setting, we're going to overdose them. So considering the risk of overdose when we start supervising something that was previously unsupervised, I think is really, really important. We're certainly very keen on getting hold of confirmation of methadone scripts so that they can be continued for patients coming into prison. I love the idea of making contact with the court by video link so that you can identify those people who are coming in and get that confirmation before their pharmacies shut. That's just a great idea. I would say probably about half the people who come in our area, in Leeds, are already on a methadone script, so if we can continue it, it's obviously much better to do so. Analgesia is tricky, isn't it? Because we know that we've got a population group who've suffered trauma, fractures and so on. Of course, old plated fractures from 10 years ago are most unlikely to be painful. Neuropathic pain arising from a tiny scar or even a healed leg ulcer where there's no evidence of any motor or sensory disturbance, it's unlikely that that neuropathic pain is genuine. I have to say that I started working in prisons in 2000, several years before pregabalin existed. And I never saw anybody with shooting pain until about 2007. And since then, everyone's got it. But you've also got a group of patients who maybe have poor alternative coping strategies. I fell down some concrete steps the other day, and I'm in a great deal of pain when I sit down, so standing's great, but I haven't gone for the pre-gabs. Settle with gin. But one of the other things with people who use drugs is there is an immediate gratification need. I've got a problem, I can solve it now with a pill. And getting over that is quite a tricky thing to do. It can take a long, long time, can't it? Pain specialists argue about this until the cows come home. Does opiate hyperalgesia exist or not? So in other words, if you're someone who uses opiates, whether prescribed or illicitly, do your pain responses change? Well, it kind of makes sense that they do. We heard about the dopamine receptors and how they will be regulated when you have patients on antipsychotic drugs. It makes just as much sense, surely, if you have all of your opiate receptors full of opiates all the time, that your body's going to say, well, hang on, where's my pain? I need to have pain as a warning system, so I'm going to put out more opiate pain receptors and tweak their sensitivity. So it kind of makes sense to me that opiate hyperalgesia does exist. And then that means that somebody who's used to using opiates is going to feel pain more than someone who's not used to opiates. And untreated pain is a problem. There's no doubt that if you have somebody who's in recovery and has untreated pain, that is a risk for relapse. There's no doubt about that. Now, treating pain does not necessarily mean using drugs. However, it can do a bit. We should be very cautious in applying the analgesic ladder to chronic pain. It doesn't work. The doyenne of pain management in secure environments, Kathy Stannard, is absolutely clear on this, that if we start with paracetamol and anti-inflammatories, those things are going to work where they're going to logically work. So if you have inflammation, you need an anti-inflammatory. If you have acute pain, that's pain for up to 6 weeks, you may need an opioid. After 6 weeks, opioids are probably worse than useless for managing pain. And therefore, we should be very careful in continuing to prescribe beyond 6 weeks after a painful incident. Tramadol, my feeling is that on one level it's probably one of the safer ones to use in prison on the grounds that it's once daily and it can be supervised, but then at the same time it can be regurgitated and sold. The antidepressant type activity of tramadol means lots of interactions. You've got patients on other psychotropics, risk of serotonin syndrome. Again, I've not tripped over dozens of corpses who died of serotonin syndrome, but I have come across a case where a patient died of it in a prison setting. So we mustn't negate that. So seeking to reduce polypharmacy, as I say, benzo alcohol detoxes I will only do if necessary. Lots of people come in saying I need a detox. When I point out that actually a detox is only going to reduce the chances of you having a fit when you suddenly stop drinking, you can't get rid of that risk at all. You're just seeking to manage it. And nothing is going to take away your rebound anxiety and insomnia. One of my top tips that I didn't write down earlier is I explain to people that benzos and alcohol are a bit like borrowing money from the bank. You will always pay back more in rebound anxiety and insomnia and withdrawal symptoms than you ever get in terms of relief of anxiety. So these things are best just not to get involved with in the first place. When you're doing multiple detoxes, the most dangerous, as we all know, is alcohol, so probably detox from that first. Then look at benzos, and only once we have stability from those, would we then look to detox from opiate substitution? I think, Dave, your point about giving people methadone and maybe taking away an opportunity for recovery is absolutely right. At the end of the day, methadone is there until people are in a position where they're ready to go through to recovery. But I think we've been guilty in the past of keeping people on it too long because it's the easy option. But equally, we don't want to be detoxing people just before they go home because of the risk of drug-related death through loss of tolerance. So it's a balancing act. Right, I went back through all the Regulation 28s. Those of you who know me will know that I've been doing medico-legal work for the last 3 years, so it makes you a complete bore, as you've probably discovered. So I had nothing to do the other day when I was preparing this, so I went through the last 10 years of Regulation 28s in relation to secure settings. And interestingly, I only found 2 relating to drug-related deaths in secure environments. One was 3 years ago. It's a mixed drug overdose, typically not all prescribed, so some of it was acquired from other people. And there was a lack of joined-up multidisciplinary approach. That goes back to the first thing that we heard this morning, Tim, about how important it is that we all work closely together. As I pointed out, not checking the mouth, that was mentioned, and insufficient cell searches. It's great to hear about medication checks, spot checks and audits, identifying people who don't have what they should have, and therefore being able to stop their meds because they're obviously trading. So that was one of the 2 that I found. The other was also 2015. I thought it was a bit older than that. Anyway, so this patient was given citalopram, methadone, tramadol, diazepam and valproate without being seen. What's the big error on that? Yeah, how many people still don't know about that? Right, so what do you do when you're taking people off meds? Well, complaints are very common, but they tend not to get escalated because there is recognition of our consistent approach, our consensus view. When we rationally respond to complaints, if you diss off a complaint and just say, that's how it is, buddy, it's going to come back. Whereas if we actually explain, possibly face-to-face with the patient, as Ben was talking about in his complex patient clinics, rational reasoning actually can work quite well. GMC referrals, well, they do happen, but the GMC are very wise to drug-seeking behaviour among people who use drugs. So if justified, unlikely to proceed. Yeah, that's our decision making. If it's justified, if the complaint is justified, it's very likely to proceed. We don't want that happening. Yeah. And litigation, lots of litigation threats. I've been threatened with lawsuits on so many occasions. I've really lost count. But when I point out that I was involved in most of those things that Denise Farmer referred to in terms of writing the national guidelines, they tend to say, "Oh, actually, we're not going to pursue that." So don't worry about threats of legal action because Bolam, you remember the Bolam defence is a body of reasonable practitioners in the same specialty. If they all say the same thing, you're going to be okay. That was qualified in the 1980s by a case called Polypharmacy, where the High Court determined that Bolam was only okay if the doctors or clinicians involved weren't all mad. Because if you get 6 mad doctors, that's a subcultural belief, but they're still mad. So Polypharmacy says they have to be sane as well, so it's got to be logical. And if you're quoting safety, polypharmacy is extremely dangerous. The majority of drug-related deaths are down to polypharmacy. So you are highly unlikely to end up successfully the subject of litigation if you document, and document. And finally, the court. We lose sight sometimes of what the court's there for. The court is there to decide on matters of fact and to decide on matters of law. So if I say you hit me and you say you didn't, it's the court that will decide whether you hit me or not. If, as a medic, I go in and say, this guy was on multiple sedating meds at the same time, I was very concerned for his safety, and therefore I gradually withdrew them one at a time, starting with the most dangerous first, no court in the land is going to find against you, because they're not going to challenge a clinical decision that's rational, because they're not clinical. So we mustn't worry too much about that. Right. Some of my techniques that I've learnt over the years, explaining safety. Dave, you hit the nail on the head. When you say, this is really dangerous, say, I don't care, kill me now. Challenging by saying, actually the pre-gab is really part of your drug problem, it's not the solution. It doesn't work either. Sometimes, if you point out that someone's on methadone and pregabalin, they are on the strongest painkillers known to man when they're not in pain. What happens if you are in pain in the future? You will get paracetamol because we've got nothing else to offer you. That can work. But the thing that definitely works is consistency of message, consistency of application, consistency between different establishments. So if we can make a consensus statement and actually stick to it, then we're going to be streets ahead. We're going to be helping patients to achieve the recovery that they sometimes can't see that they are capable of. But we're also going to prevent deaths and an awful lot of morbidity and an awful lot of disturbance of prison regime by prison officers having to escort people to outside hospital. The final thing that really does work is to have a robust written policy which you can blame. And if you like, you can blame me. And if you can't remember my name, Nat Wright's just at the back. He'll do just as well, because I've blamed him hundreds of times. Brilliant. So I don't think I've got anything else to say, but I do believe that there's going to be an opportunity for some questions over the next few minutes. But thank you very much, and thank you for not dying of boredom after me trying to follow Dave.
Okay, so we're doing well. We have some time for questions. We have coffee after that. I know you're all desperate for the caffeine here because we're still all addicted to caffeine. Question?
Just a quick practical one on antihistamines of all things, but obviously we're inundated at the moment because of the hay fever season and the pollen. But I wasn't aware particularly of the potential combined with everything else. Are people giving them in possession, or are we not in possession? What's the general thing on antihistamines?
Well, the first thing is to choose one that's not sedating. So I'm a loratadine fan. I mean, they're the same, much the same. My usual approach is antihistamines for itchy eyes and steroid nasal sprays for nasal symptoms. And if there's no other concerns about, say, an ACT or something like that, I would give it weekly IP. Some consensus there?
I wondered if you changed your approach with pregnant prisoners with regards to rationalising the medications when they come in?
Yeah, pregnant. I am one of the doctors who does work with females working at Newhall, and pregnancy is a very significant concern. My first thing to do is to take advice. I'm a GP. I used to do lots of antenatal and obstetric work in the distant past, but that's a long time past. My general view as a GP when dealing with pregnant patients is to change as little as possible and to do so as slowly as possible whilst working with the experts in the field. But I'd probably be a bit more careful about asking about compliance, taking a good history, documenting that very carefully. But I probably wouldn't go in all guns blazing trying to get rid of everything and simplifying polypharmacy on the first night. I would be doing it much more gradually, and most definitely with expert opinion.
Which expert are you thinking would be?
Well,
Sometimes they're not actually justified for specific conditions.
yeah.
So,
Right, well, obstetrics would be taking their advice because it's...
Pregabalin reduction?
Well, pregabalin, my habit has always been to reduce by 50 or 100 milligrams a week, which is something that I started doing before there was any guidance because it seemed vaguely sensible. I think that if the woman was on pregabalin and there was no good indication for that, and I'd have to check if pregabalin is something that she should be on anyway when she's pregnant, I would be doing that reduction at the slower end, so 50 a week, perhaps 50 a fortnight, on the grounds that I don't want to upset her metabolically during a pregnancy. And it depends how far on she is, what the gestation is, doesn't it, and various other things. But I'd certainly want to know what her concordance was like, and I'd be putting some pressure on to find out about that, because if she's selling it, then we don't have a problem. If she's taking it regularly, I'm going to be more cautious for sure. If that answers the question.
Yes, I mean, yes, it does. I've got a difficulty with the specialist because, often you don't get that information for various reasons, and you haven't got time maybe to be, waiting for answers and things like that. And I would have thought of asking an obstetrician about those medication advices, but that's interesting.
Well, they are going to deal with your opiate dependent baby, aren't they? With peds, they're going to deal with lots of other. I mean, if you take the valproate thing, for instance. If we have someone who's unfortunate enough to be pregnant on valproate, which is the next medico-legal minefield, we're seeing that already, then that's obstetrics as well, together with neurology. So I think there is expertise there, and I would always, as a prison GP, tap into that.